right. Okay, so we are going to move on to our next speaker, who is another one of my favorite people. We have Kate Dobler here, who has just been so instrumental in really moving the community related to maternal substance use. And so I'm just going to give a brief introduction, and I think she will take it away. All right, so Kate Dobler has 15 years of progressively responsible experience driving positive bottom line results for state of Arizona agencies by overseeing system development and improvement. She has a master's of education and is an award-winning, community-minded system change agent with deep experience in driving system change, building networks, and organizing grassroots community groups. She's an exemplary partner, transformational leader, team builder, staff and community partner, coach, and mentor. She's also, we should note, the mother of 2 terrific kids, 2 chocolate labs, and 4 brand new chicks. All right, Kate, I will let you take it away.
Thanks so much, Katie, and thank you for the opportunity to present today. It's nice to see so many folks on the call. So yes, my name is Kate Dobler. Thank you for the introduction. And I serve as a state's project director for a pilot project for the treatment of pregnant and postpartum women with substance use disorder, and truly come to this work with the belief that we are better together and that recovery is possible and we all deserve do-overs. So next slide. So this is a SAMHSA funded grant. This is the long name that it does not flow easily off the tongue. So we lovingly refer to this project as PPWPLT. And this is our grant number under SAMHSA. Next slide. So again, this is the funding source. I just want to start with some background information on the pilot project itself. So it was initially awarded in late August of 2020 with a begin date of August 31 and an end date of a 3-year pilot project of August 30, 2023. So we're a little more than halfway through the last year. Funded amount at $900,000 per year, and it specifically identifies creating an opportunity for a cross-sector learning collaborative and providing related training and conversations statewide. And then we do have a direct service component. And our target population is pregnant or postpartum women. This is language from SAMHSA, but pregnant or postpartum people diagnosed with substance use disorder together with their children. So really this does take a dyad and family approach to care. Next slide. So I wanted to, this is a little busy, but I want to frame it for you. When this project began, when we applied as a state in early 2020, this was the very end of the governor's office funded and spearheaded neonatal abstinence syndrome action plan at the statewide level. And our action steps as a state to support new planning initiatives and projects. So the gray squares, the arrow in the background, that's what was in place at the end of 2020. And then you can see I've added in some additional colors of work and initiatives that are happening now. And so we have 2 inpatient behavioral health treatment licensed behavioral health facilities supporting newborns to move through the withdrawal period, Hushabye Nursery and Jacob's Hope. They both became active in seeing patients in 2020. We have a statewide Best for Babies HRSA funded effort that is being spearheaded by Prevent Child Abuse Arizona out of Yavapai. We have a couple of shift collaboratives across the state. In 2019, 2020, we had Maricopa County and Yavapai was a pilot just beginning. Now we have shift initiatives in Coconino County, Pinal County, Yavapai County, Maricopa County, and a statewide leadership team that's just about to break into some work-focused subcommittees. And then we have some really exciting reapplications that have happened. Arizona Rural Women's Health is reapplying for the ARC Corps. Maggie's Place is opening a 5th house in Phoenix. Magnolia House in the West Valley of Phoenix has opened a pregnant postpartum women with children at risk for substance use disorder, if not actively diagnosed. And they have a couple of additional apartment style houses that they're in the process of opening as well. And then we have Lifewell Behavioral Health has created additional beds in their residential program. So we have some significant growth in this space, which is really fantastic. Next slide. So there were 3 underlying goals for this PPW PLT project, really looking at what's in those circles, but we wanted to create a continuum of effective wraparound recovery support systems that really met moms and babies and families where they are within their process around treatment and recovery for substance use disorder and withdrawal within the baby, but also recognizing that mom where she is with what she needs. To do this through responsive outreach, engagement, and consistent screening and assessment, and then creating meaningful, workable, accessible access to outpatient menu of services that's really focused on the pregnant person and her family and the resources they need. Next slide. Just want to take a moment to define the terms, just so that we're all clear. So this is a great visual that I borrowed from Dr. English. Jenny just referenced her work in this space. But really, this project is looking at substance exposed newborns to any substance. So not only opiate withdrawal, but also methamphetamine, alcohol, heroin, whatever the exposure might have been. And so we do have 3 different layers of terms that you might hear, but wanted to identify that they are sort of 3 different bundles of symptomology. And this project is really working to support moms and babies who have experience with any sort of substance prenatally or postpartum. Next slide. So one of our deliverables was a needs assessment. So this is a statewide needs assessment that was done in 2020. 21, completed in the summer of 2021. So this highlights the parts of the sector and across the state that we identified. It was a multivariate, multimodal data collection effort, qualitative and quantitative data, and then several focus groups and key informant interviews to really learn or get a sense of the experience of people who are pregnant and postpartum and diagnosed with substance use disorder, as well as the experiences of their physicians. So really wanting to look at both sides of that equation, and then begin to get an understanding of what the array of treatment options looks like in Arizona. So these are some primary findings, not a surprise to any of us on the call, but these are data points from respondents in Arizona. Next slide. These are some recommendations that came out of that needs assessment, and they really speak to the need for multi-systemic collaborative approach to reach the population. Those are pretty words from SAMHSA, but it's all true. That's the work that we're doing here in translational research, and within the work of the collaborative and all of the statewide groups that are presenting today. Really needing to shift the culture to inform on pregnant and postpartum women, and the resources available to this population to support recovery and treatment. Providers need more training and support to understand and feel comfortable and confident and competent in treating the population. We need to address stigma, and we need to address the impact of stigma and bias on resources available for this population of parents. We need to expand earlier access to screening and have multiple points of entry. So the no wrong door approach it is a thing we need to do, and we need to focus on across the system. So these are, again, not new recommendations, but these did come out of the conversations and data collection and analysis that we did. In particular, supporting the mother-baby dyad through constructs like and models of caregiving like Eat, Sleep, and Console, which really focuses on the base of it, the attachment and the bond between a mother and her baby. That is the basis of everything that comes later. And as you might guess, babies like their moms. So this is a good approach. Next slide. So stigma within the pregnant and postpartum populations. So these are the overriding themes that are coming out. We have a significant loss of a feeling of support systems, internal stigma within the parent, and already feeling like they have done something wrong and bad, and already harmed their baby. They already feel bad enough, yet they face a significant amount of shame in healthcare settings that they may engage in, or choose not to engage in because the bias and stigma and shame is so extreme. And there's a consistent sort of cross-cutting fear of Department of Child Safety involvement and the potential loss of their parental rights. And these are reasons that prevent pregnant people, postpartum people, from accessing treatment. And that is not best practice. That's not good to hear. It's not easy to see those words, but this is what we see. Next slide. So wanting to look a little bit more at opiate use disorder in pregnancy. Next slide. So in the PPW PLT overall project, we have a workforce development component, and we've done a significant amount of work with Dr. Manriquez and her team at the University of Arizona College of Medicine out of Phoenix. They have created a couple of sets of YouTube, there are webinars that are recorded and available on these YouTube links that are specific to various components of understanding treatment within the dyad or between the dyad of mom and baby and provider and mom, working through substance use disorder treatment and the components of that care and what it would look like to be trauma informed, to understand what is medication for opiate use disorder, what is the intersection between breastfeeding and NAT, how do we have those conversations? So those are the content points, recognizing that physicians have access to online training typically, but frontline staff and people doing the work directly with families typically don't. And so these webinars were created to make that best practice and research available and accessible, free at no charge to people who are doing the work directly with families, so that we can create a toolbox for folks that are feeling disconnected and out there on their own, on an island by themselves. Next slide. So one of the primary points of education that we continue to get, the need for education, is understanding opiate use disorder and pregnancy, and really needing to hone in on what is best practice, why treatment matters, why medication to assist with treatment, medication for opiate use disorder is the gold standard of care. Why do we feel so strongly as a system that we need to support in this way with this kind of comprehensive treatment? Because this is the best outcome for mom and baby during pregnancy. So this is an info sheet that's been created by the American College of Obstetrics and Gynecologists. And it begins to outline the benefits of and really the gold standard of treatment and medication with methadone or buprenorphine. And yes, they do cause short-term withdrawal symptoms, and they do identify some of those non-pharmacological treatment, sort of getting back to hold the baby. The babies like to be held. Well, they need to be held, and they need skin to skin. They need to be breastfed. They need to be swaddled. And so this sheet does a good job of tying that all together. This is information that needs to be out there and available more widely than it is. There's a lot of discomfort and lack of knowledge. So pulling some information together is part of the work of educating our workforce. Next slide. So this is another piece of messaging from SAMHSA. So how can pregnancy affect treatment for opiate use disorder? This is another significant question within the field, within home visitors, within parents, within early care and education sectors across the board. So no, you should not stop your opiate use disorder treatment medications during pregnancy. That is not medically indicated. It's not safe for mom or baby. It is much safer to continue to see your treatment provider and adjust those doses as necessary, because blood volume changes, hormonal balances change, and the need and metabolism for medication changes during pregnancy. And withdrawal in this time poses significant risk for mom and baby. And it is really very dangerous to not be medicated during pregnancy, and the risk for relapse is incredibly high. Next slide. So parents are magic. In case that's not clear after the conversation that Jenny just had, they are the best medicine for their baby. Next slide. So when we look at models of caregiving that support that infant, that newborn parent bonding, from the very beginning of life, if we just look at the fact that a baby doesn't exist independent of its parent. We heard Molly talk about that today, and the significance of the security of that attachment that begins immediately after birth. And we heard Jenny talk about breastfeeding and the challenges that moms have if the baby has not been at the breast, and to reestablish breastfeeding, lots of relearning and sort of reconnecting that needs to happen in that space. If we can keep that connection in place, babies do better, they breastfeed better. And we can see some data here that looks at infants who were born diagnosed substance exposed, and the dyads that were treated, the mother baby dyads that were treated and roomed in together, and their sort of how they did. And so infants are roomed in with their mothers for at least one night, had an average length of stay of 7 days compared to 17 days among infants who were moved to specialty care nursery or NICU or somewhere else in the hospital, not with their mom. 38% required pharmacological treatment, 64% of infants, those infants who did not room in, needed twice the number of those infants required pharmacological intervention. The rest of those babies were held responsibly, fed responsibly on demand, and did much better. Breastfeeding, when breastfeeding is promoted, we see the median length of stay down to 7 compared to 11 days for babies who were not given breast milk. In addition, 36% of infants who received breast milk required pharmacological treatment, compared to 51% of infants who were formula fed. And then we see the importance of engaging families in infant care and receiving skin-to-skin contact. So this is significantly important in this population. Next slide. So just some data looking at the power of this intervention that was just described in the previous slide. So all that happened in this subset of 6 hospitals who were funded to look at how could they reduce the need for pharmacological treatment within this dyad, and what would be the impact of simply rooming in. And that's really all that they looked at. So you can see the results from the implementation of one intervention only. They only looked at whether the baby roomed in for at least one night if those babies were diagnosed with neonatal abstinence syndrome. You can see that average line is the dark blue line. So before the intervention, they saw 66% of infants in this population required pharmacological treatment. Once they were the group that was rooming in for at least one night, that being the only thing that was measured among everything else, but only looking at that, after the intervention, that percentage of infants requiring pharmacological treatment dropped to 42% by rooming in only, because that means they're having responsive skin-to-skin contact, because mom and family are magic and they are the medicine the babies need. Next slide. So what do non-pharmacological interventions look like in this space? We want to promote breastfeeding. We want to engage families in care. We want to connect mothers to peer support and community supports. We want to have volunteer cuddlers and other folks available to respond to that baby's cry when they cry, because they're communicating a need and it needs to be met. Because again, back to Molly's content, we want to create the environment where baby knows they can be safe. And we want to support rooming in between mom and baby. Next slide. So what does the eat, sleep, and console assessment basically look like? These are the primary questions. As Dr. Grossman says, this is the job description of a baby. They need to eat, they need to sleep, and they need to be able to calm down. If they can do that, they're doing pretty well. That's what their job description is for a newborn. So can they eat at least 1 ounce per feeding, or can they breastfeed well? Can they sleep at least an hour? And can they be consoled within 10 minutes? If they can, great. They need to consider continue the non-pharmacological treatment. If they're fussy, if they're uncomfortable, if they are hungry, if they're not sleeping well, then treat them like a baby and do baby things. So pick up the baby, hold them, rock them, change their diaper, turn the light off, turn the light on, cover them up, uncover them, try those things. And then if that doesn't work, then proceed to dosing on a PRN basis with morphine as a full agonist for infants who are opiate exposed. Next slide. Liz. So these are pictures that I just wanted to show you of moms and babies. Here's the reality. Next slide. So mother-infant dyads, typical stressors, a new mom, a new baby, difficulty latching, generally feeling clumsy and nervous and tired, and you can't sleep. You're in pain from recovery. You're exhausted. The rug has just been jerked out from underneath your family. You've added a new baby. Next slide. And we know that babies are born into relationships. We know that attachment and bonding between newborn and their primary caregiver is required for survival. We're not talking about thriving. We're talking about baby living requires an attachment and a bonding, and it should be the focus of care. Next slide. So I don't think we have time for this. I have like 3 minutes left, but I would encourage you to think about what ideas do you have about how your work could be more powerfully support dyads and be more focused and family friendly and supporting the bonding and stability of that dyad. I can ask you to consider that and consider whether you know who those partners are that you would reach out to support that dyad. Next slide. So what gets in the way of successful treatment for substance use disorder? Whole host of things that we've talked about today a couple of times. So I'm not going to read this. You'll get slides, but we know this gets in the way. Next slide. We know that we don't have a distribution of behavioral health providers that's equitable across our state or available. We know providers are less likely to accept pregnant women, and that we know that access to insurance coverage services is challenging for this population, particularly in women who are struggling with opioid use disorder, and lack of clarity and training around clinical. Let's talk about that today. Next slide. So it takes to raise a child, and it takes a village to support that child's parent. This is sort of a theme this morning. So think about who's your village, who else is serving your families along with you. You're not out there on your own. It takes all of us to do this work. Next slide. Because recovery is possible. Next slide. And we are at 11:38. I see questions, although I can't read them. So I will defer to whoever's managing the Q&A. Thank you for the time today.
Hi, thank you so much, Kate. I'm managing the Q&A for this session. And your first question is from Marina Taylor. And she's saying, in the needs assessment, why AHCCS participants only? Why not insurance participants also?
So for this funding model, I can't see the question, so I'm not sure, but access coverage was required for the population of women who can participate in the pilot direct service, part of this model, and that's a requirement in the application. Was that the question? I can't.
Yeah, it says in the need assessment, why AHCCS participants only? Why not insurance participants also?
So in the needs assessment, we surveyed across the state and all populations. But in Arizona, the substance use disorder treatment block dollars are administered through our regional behavioral health authority health plans. And so they have the widest reach for the patient population, but treatment resources are available across the state for anyone, not only access eligible.
Okay, thank you so much. The next question is from Anna Cosgrove, and they're asking, where can we find some of the resources you shared in your presentation?
So Liz, I'm assuming slides will go out as part of the conference materials. The YouTube links are available and they're live in those slides. And you can, I'm happy to share with Liz, or Liz can share. There's a access webpage for the PPW project. And if you are interested in joining the Learning Collaborative, I am hoping that you will let me know. So again, sorry, I'm seeing a comment from Liz about typing questions and responses in Q&A. I will absolutely. You can certainly join the Learning Collaborative, and I'm happy to present information and share information from the collaborative and add you to that distribution list, whoever would like to join.
Okay, thank you. So the next question is from Dr. Michael Ned.
I'm sorry to interrupt, but we're going to have to transition to our next presenters. It's a shorter time frame, so we don't want to go over. But Kate, thank you so much for your presentation and your ongoing work and your commitment. And it's so great to have you here.